The next skills we're going to be talking about is enteral and parentral nutrition. So what these things are. So enteral nutritional feedings is any method of feeding that utilizes the GI tract. So we're using the normal anatomy and people are digesting food the normal way that they would. We're not talking, I mean, you can consider oral nutrition, like regular just eating food, enteral nutrition, but it's a little weird to talk about it in that context. So we're really talking about artificial means of inserting nutrition using the GI tract. So things like PEG tubes, which stands for percutaneous enterogastric, percutaneous through the skin, entero into gastric, stomach, so through the skin into the stomach tube is really what we're talking about. Also NG tube feedings, so nasogastric tube, which is a tube inserted in the nose, goes to the gastric, goes to the stomach. Parenteral nutrition, by contrast, means that we are not utilizing the GI tract. This is nutrition infused directly into the venous supply, meaning it's immediately bioavailable for all the cells of the body. The things that we're talking about for parenteral nutrition are TPN and PPN. TPN meaning total parenteral nutrition, and PPN meaning partial parenteral nutrition. And what this is, it's a liquid, it's infused like an IV solution, but it is just carbohydrates, proteins, fats, and electrolytes. Like that is it. It is already broken down into the smallest bioavailable kind of molecule that can be utilized by the cells of the body. And we're going to talk much more about both of those types of nutrition in this section. So the types of tubes used for enteral feeding. This first part is all about enteral feeding. So things utilizing the GI tract, utilizing digestion. So we have surgically placed tubes, which are PEG tubes, which are usually, you can see them kind of sticking out of the abdominal wall, right where a patient's stomach is, and PEJ tubes, which is percutaneous endoscopic jejunostomy tubes. So not going into the stomach, but going into the jejunum, just distal to the stomach. So really it's about where those tubes are placed, which changes the name. And then our non-surgically placed tubes. So we have NG tubes, which are inserted through the nose into the stomach, which is what this patient has here. You can just see it going around her cheek, through her nose, into her stomach. Or we have NJ tubes, which same thing, but it's going to the jejunum. So just a little bit further on the patient in their digestive tract. So when we think about using enteral tubes or enteral feedings through tubes, can we use these things for? Here's an example of an NG tube, and this is about what your patients are going to look like when you put an NG tube in them. Like, this sucks. It is not a fun procedure for anybody to go through. So that kind of look of like, what the hell just happened to my life, that is a normal thing for patients with NG tubes. So the feedings that can be done. So we can feed patients nutrition through these enteral tubes, whether they're surgical or whether they're non-surgical. So we can do tube feedings, which looks like this kind of stuff. It's one of those unique products that looks exactly the same going in as it does coming out, which is always a plus-ish, along with water. So anytime we're giving enteral feeding, we always want to supplement with water because that's how patients remain hydrated. These are different products that can be used. Any type of tube feeding that can be administered through an NG tube can also match a patient's medical diet, meaning there's a cardiac formulary, a renal formulary, a diabetic formulary for whatever kind of diet modification a patient needs to be on. Important thing to note is that the tubing and this whole system, everything that gets attached to it, so the bags, the tubing, all of that, it's only good for 24 hours as a closed system. Because there's so much nutrient content in these things, the risk of bacteria getting in there and just like going nuts is super high. So every 24 hours we strip this stuff down and get a new set of tubing and a new container of tube feed for our patient. If the system is open, meaning it's these bags where we get kind of like almost like soda cans full of tube feed, and we can just dump them in these bags, that would be an open system. That is only good for 8 hours. So end of our shift or during our shift, we're gonna hang a set, give it to our patient and tear it down, throw it away, because again, the risk of contamination is just so high. Body positioning for tube feeding, super important. These patients have to be at least semi to high Fowler. So at a minimum in bed with a 30-degree angle on the head, up to higher. The risk of aspiration is enormous for patients who are getting tube feeds. Other things we can do with these tubes, we can give drugs through them, but the drugs must be crushed into a fine powder. Very, very, very fine powder, not a chunky powder, fine powder. Got a video here on how to do that. Again, the links will be down in the description. Then we want to reconstitute that powder with water and then flush per hospital protocol. So it's kind of the same as giving IV medications. Anytime you're going to put a medication through any tube in the body, the procedure is always flush it to make sure it works properly, then give your medicine, and then flush it again to clean it out. Whether it's IV, whether it's central line, whether it's one of these feeding tubes, an Entral tube, whether it's surgically placed, non-surgically placed, does not matter. The procedure is the same. Flush, meds, flush is the way we do that. Tube feeding and drugs, we treat them exactly the same way. So anything that goes through this tube, flush, stuff, flush. And we also need to verify the placement of these devices prior to utilizing them, just to make sure that it is safe for this poor woman to receive some kind of treatment through that device hanging out of her nose. So prior to use, what we're doing is we need to verify patency. So a couple things we can do. One, ask the patient to speak. If the patient can't speak, that means the tube has relocated from the esophagus to the trachea. That's the big thing we're looking for. Those tubes run right next to each other down the patient's throat into either the stomach or the lungs, and that's the big risk. So if the patient can speak, that means there's not a tube in her trachea that's impairing the mobility of the vocal cords. So that is always a good sign. Then inspect the securing point, like where it is on their nose. Make sure it hasn't dislodged or slid in or out of the patient. So we're just kind of double checking the length of the tubing. Then we want to aspirate stomach contents. So you get one of those 60 cc syringes with like the tip on it, and you hook it up to that NG tube and you just pull out anything that's in there. If you get liquid, perfect. We can pH test that. So it's special paper that you put that liquid on and it turns green or a certain color once with low pH exposure to liquid, which is what stomach acid should be. It should be very low pH because it's very acidic. And then finally we can inject air into the tube, into the NG tube. So same syringe, but you just draw back some air, and when you inject that, you listen with your stethoscope right below their xiphoid, right over their stomach, and we're listening for gurgles as we're injecting. So you're listening through your stethoscope at the same time you're injecting air into that NG tube, and you'll hear like gurgle, gurgle. It's going to sound amazing, but it's confirmation that that tube is in fact in the stomach. If it was in the lungs, there would be no gurgling. And then routine maintenance of this thing. So if patients are getting food and fluids through this thing, what we want to do is flush it with free water before and after every use. So that's the cleaning. And we can just use tap water for this. It does not have to be sterile. GI tract isn't sterile, so the stuff going in there does not have to be sterile. Then we're going to flush this thing Q4 if we're giving continuous tube feeds. So if we're giving this kind of system right here, where they're getting like a prescribed rate of tube feed, almost like an IV infusion, then we're going to add a free water flush every 4 hours just to maintain appropriate hydration and make sure that the actual NG tube stays clear and doesn't clog up. Sterile water for immunocompromised patients, It's kind of like those neutropenic kind of precautions. For patients immunocompromised, we want to minimize their exposure to external pathogens, so we can use sterile water. Normal saline for patients with low sodium, but now we're infusing medications as part of our free water, because normal saline is a medication. So this is a prescription kind of thing. So that's infusing a medication orally. So we want to check on that. If you're putting an NG tube in, first thing you must do after that tube is in is make sure it is in the right place. And we do that using one of those 4 ways, all those 4 ways that we just described. But for initial placement, the key thing we do is we take an X-ray. The tubes are radio opaque, so we can actually see them. So this is one that's going straight down their esophagus to the bottom of their stomach, where it makes a nice little curve, which is lovely. That's appropriate placement. This one is going right down something, and then it hits the bottom and hangs a hard right on the patient. This, as you can see anatomically, that's where the first bronchial split. So this one bottomed out in their airway and then took a hard right down the right main stem of their respiratory system. This NG tube is placed in their lung. That is bad. So what happens if you do this with a patient is they will show immediate signs of respiratory distress. So they're going to have that gasping for air look on their face, but they won't be able to gasp for air because they're actually like choking. And all we have to do if that happens, take it out. In order to get an X-ray on this patient, I imagine this person was sedated. Otherwise, they would have signs of respiratory distress like immediately. So this is normal. The way that we measure this to help make sure that we get it in the right place the first time is you measure it from the tip of the nose. So you actually take the tube and you go from the tip of the nose over the ear. Sorry, I'm doing this the wrong way. So tip of the nose over the ear, down to the xiphoid, and then we add a few inches just to make sure, because we know the xiphoid, that's about the top of the stomach. So we add a few inches just to make sure it's solidly in the stomach. Then we get our X-ray, and hopefully this is what we see. We see this nice long straight tube going straight to below the level of the diaphragm. You can see the level of the diaphragm here. This tube is clearly above it. It's in the lungs. So for the assessment on how we verify that the patient is tolerating this thing well. So the tube is in, we verified placement. How do we know that using that tube isn't causing harm to our patients? First and foremost, GI system assessment. We want to ask, look, listen, feel, all those things. So we're going to ask them any nausea, vomiting, diarrhea, see how their digestive tract is working, and then look for any abdominal distension. We want to see if it's swollen, meaning there might be an excess of air in the abdomen. Then we want to aspirate stomach contents, particularly for patients who are receiving a continuous tube feed. They should be nice and happy like this. This kiddo's like crushing his tube feed. But sometimes it can happen where patients have gastroparesis, meaning a paralysis of their stomach, where they're not digesting at an appropriate rate. And that is a concerning finding. So the residual amount, meaning the amount of tube feed or stomach contents that's in their stomach, should not be more than 1/3 of the amount of their previous feeding, or 1/3 of their hourly rate if it's a continuous tube feed. So the example would be if a patient is getting 100 milliliters an hour of tube feed. If we're aspirating stomach contents and we get more than 30 mils out of there, we're infusing that too rapidly. That patient isn't digesting it at an appropriate rate. So we're going to need to do one of two things. Either schedule in a break so that the patient can catch up with their digestion, or slow down the rate. When we first start these infusions, that's when our patient is most at risk for having gastroparesis or not digesting at the appropriate rate. So we do need to check gastric residual every 4 hours just to make sure they're tolerating that tube feeding well. Once it's initiated and the patient is stable and they've proven that they're able to keep up with the rate of infusion, then we can back off, and we do this every shift. So it's part of our routine assessment for that piece of medical equipment. If the patient isn't tolerating their tube feeding, meaning we're getting any negative symptoms from their GI assessment or they're not digesting at the appropriate rate, then that's an abnormal finding. So we do need to notify the physician of that patient's condition and the abnormality that we found. Patients who, we've said this earlier, but didn't really draw a hard underline under it, but we're going to do that right now. The greatest risk for patient receiving tube feed is aspiration. It is the regurgitation of those stomach contents just spilling over into the trachea, and then they aspirate all of that content. So the things we do to prevent that in our patient, the head of the bed has to be elevated 30 degrees, greater than 30 degrees. If they're receiving continuous tube feeds, meaning around the clock, it has to be elevated all the time. If they're getting bolus tube feeds, where we infuse, say, 600 mils of tube feed every breakfast, lunch, and dinner time, then they need to be sitting up for at least 30 to 45 minutes after that bolus is delivered. Once they're not receiving anything through their tube feed, they can lay down if they like, that kind of thing. But while that stuff is in there, we need to minimize the risk of aspiration by sitting them up. Check residuals, make sure they're digesting everything at an appropriate rate, and then we're not just backing things up in their stomach, kind of filling them up like you ate a big meal and then continuing to pour more in. So we don't want to do that. That sounds like torture. And then swallow precautions. So the kinds of things that we can do to facilitate gastric drainage and keeping things in the stomach. It's a lot of those same precautions that we do for patients with peptic ulcer disease or GERD, is upright bed position. If they're going to be taking PO liquids, we need to assess the thickness to make sure it's appropriate, because patients can sometimes swallow while they have an NG tube in. So thickened liquids might be more appropriate to facilitate appropriate swallowing. And possibly consult speech therapy just to make sure that all of this is happening safely, because we are manipulating their natural way of ingestion. So we should call in some experts to make sure we're doing that safely. That's what that's all about. So the complications, we've talked about this, aspiration. That is the big complication for tube feeds. Anytime there's a tube going in somebody's nose like this, they are at high risk for aspiration. This is like a lovely model because there's no way that that tube is inserted that long. These things are like a meter long, so like 3 feet. If that dude's swallowed like 2.5 feet of tube, he's got a really weird torso. But anyway, sorry, rabbit. Other things we want to look out for, tube displacement. So change of that positioning of that tape on the tube, dislodgement of the tape from around the nose, also a big risk. Electrolyte imbalance and fluid volume abnormalities, dehydration or overload. Definitely things we want to pay attention to with our assessments. So then shifting gears just a little bit, parenteral nutrition. So now we're looking to provide the same level of caloric and nutritional need for our patients, but we're not able to do that using their GI tract. So we're gonna do that using their vascular system through direct infusion. One of the big products we're looking to use for parenteral nutrition is TPN, or total parenteral nutrition, meaning we're looking to supplement all of their nutritional needs, caloric and electrolyte, fat content, through an IV solution. So the main components of TPN, amino acids, which is our building blocks for all the things that cells need, dextrose, which is bioavailable sugar, and lipids are the other ones, so fats. That's what makes it all milky looking like this, kind of white. So these things must be given via a central line, which is either a central venous catheter or a peripherally inserted central catheter. A central line is like an IV, but instead of the IV, the tubing ends basically 1.5 inches above where you poked them. What these will do is they are going to have tubing that once it's inserted, that tubing is so long that it goes all the way up their vasculature and always ends in their vena cava. in their superior vena cava. So what makes it a central line is that it goes right to their heart, essentially. That is the characteristic of a central line. The reason we do that is because when we infuse something through a central line, the amount of blood that circulates right at the heart is the most volume of blood that the body circulates in any place. So we have immediate dilution of that infusion at the source, like when we use a central line. And this stuff, the pH of this stuff is really caustic. It's very, very hard for veins to tolerate it. It causes inflammation. So we want to dilute that completely in the vena cava, which is why we must do a central line. These things are also super complicated. So every electrolyte that's in these, so all the sodium, potassium, magnesium, calcium, phosphorus, glucose, insulin, all the things in TPN are individual physician prescriptions, meaning we have to verify every one of those prescriptions. That's the list of prescriptions right here under this hand and here. So these are all the components that are in that TPN for that patient. All of those have to be individually verified by the physician prescription, because every line item is its own prescription. These are custom made and mixed for every patient every day based on their lab work. So very, very high stakes medication. So again, need a physician order for TPN or PPN. And that physician order has to cover all the components of that stuff. And we're checking the bag against the physician order. The bag is the drug, the physician order is in the computer, which we're gonna check. Usually dietitians or our nutritional support personnel are involved in patients who are getting TPN or PPN. Because the reason patients are gonna get this is that they're not able to naturally ingest enough caloric or nutritional need to maintain healthy kind of amount of intake. So our dietitians and our nutritionists, they're going to be the ones who are helping to guide the amount of caloric intake necessary. A couple key things with the infusion of this stuff. First, you have to start every infusion very, very slowly. Patients usually get TPN either around the clock, so a 24-hour cycle, in which case we're going to start each new bag slowly for about an hour, 50% rate for the first hour of infusion, or patients receive this overnight. So over a 12-hour shift, but during the overnight period. So every night we're going to start off the first hour infusing that stuff at 50% of the normal rate, just to make sure we don't have any complications around the infusion, any alterations in vital signs. We don't want to infuse this stuff cold. Never shove cold stuff directly into somebody's veins unless there's a very good medical reason for it. Generally, the body doesn't like that. We also need to use a filter on this TPN or PPN product. These products require special tubing, so you're always going to be using TPN tubing for infusion of TPN. We've got to have, that's not a sterile procedure using this, but you got to be pretty darn close. Because this stuff is so full of sugar and nutrients, just like enteral feedings, if any bacteria gets in there, we're going to cause sepsis in this patient. So we need to be really, really aseptic in how we prime all this tubing and prepare this infusion. All the tubing, the bag is only good for 24 hours. Honestly, we're never going to use this stuff longer than that. As soon as the bag is empty, you tear it all down and you put up a fresh set with every infusion. So if you're getting it overnight, it's only good for that overnight time. If it's a 24-hour cycle, you infuse it over 24 hours and you tear it down, and with the next bag, you put in a whole fresh setup. The other big deal is that you need to wean patients off their infusion very, very, very slowly. The reason for that, so what that, before I get into the reason, what that looks like is just like when we start at 50%. For the last hour, we drop it down to 50% again. So we taper off that infusion of medication. Reason for that is when people normally digest food enterally, they have what's called the first pass effect, where most of the blood supply that's absorbing nutrient from the GI tract first goes to the liver before it enters primary circulation. The liver then can store glucose, manage glucagon levels, things like that. So when we directly infuse into the vasculature, we bypass the liver's first pass effect. So when we dump glucose into the patient, we are literally just dumping glucose into the patient. We are going to cause hyperglycemia in these patients. Also, when we take away the glucose, Their body is still producing insulin based on the amount of glucose in circulation, but they no longer have the glucose. So rebound hypoglycemia at the end of infusion is a very, very serious nursing concern that we need to pay attention to at the end of every infusion of TPN or PPN in our patients. So complications. First, there's complications with the actual catheters. So the catheters themselves can become occluded, meaning a blood clot can form. And anytime there's a blood clot, we worry about strokes, then we worry about dying, that whole cascade of horrible, bad, terrible kind of things. Others is infection. So we worry about contamination somewhere in the system, which can cause sepsis in our patient and dead, which is bad. The other big one is air embolism. So we want to make sure there's no air in the tubing, that we can give patient an air embolism. What can happen if you give a very significant air embolism to a patient is that it can cause a sudden loss of cardiac output. So if the entire chamber of the heart is full of air, it's obviously not going to pump any blood. So that's dead. Cardiac output is necessary for life. So if you lose that, no bueno there. If you do suspect that there may be an air embolism in your patient and they're still alive, we want to rescue them from that air embolism. So you're going to place your patient in left Trendelenburg and call the MD. We're trying to position our patient so that they can't get into the left ventricle and get shot out into circulation. We want to try and trap it in the atria of the heart. But that's only if you suspect a very large volume. We don't do that for every little bubble that's in IV tubing, that kind of thing. It's really if you infuse a whole tubing set full of air, that would be very, very bad. So human-associated risks, so electrolyte imbalance is a big one. If we mixed this stuff incorrectly based on their lab work, that would be horrible. We can cause all kinds of electrolyte abnormalities to this poor young woman because of that flood of electrolytes directly into the body. The other big one is diabetes patients, especially type 1 diabetics who are not producing insulin. Their risk of hypo or hyperglycemia is very, very, very high. So we have to be very sensitive to that. On average, patients tend to run much higher than normal for their blood glucose while they're getting TPN, and we accept that that's normal given this infusion. So we always check the glucose level on these patients every 6 hours. And always assess for the polys for any diabetic patients. So polyuria, polydipsia, and drew a blank on the third one, drinking too much, peeing too much, and I can't, totally drawing a blank, but when it comes back, I'll let you know. But that's what we're looking at for. And then these other complications of hyperglycemic states. So HHNC is like a severe diabetic ketoacidotic kind of situation where the patient is severely dehydrated because of electrolyte disturbances intravascularly. So they get seizure, coma, death kind of thing. Really, really, really big problem. Patients are at risk for this if they have sustained blood glucose levels that are extremely high, greater than 600 for 24 hours would be really, really bad. So if the order for TPN is DC'd mid-infusion, do we just turn it off because the order has been discontinued? No. If we're going to stop midstream, we have to do a slow taper, just like the end of an infusion. So we always, always, always do that slow taper to finish it off for our patients. That's it for enteral and parentral. The last one we're going to talk about is our blood transfusions.